Well, good morning to everybody. My name is Ana Paula Velez. I'm one of the infectious diseases attendings here for the University of South Florida. And today we'll be talking about the 20 skin infections that an internist should know, and obviously an infectious diseases physician should know, of course. What you see here is a painting of a polymicrobial abscess, from a fluid of polymicrobial abscess. So you can see all the gram-positive cocci in chains and pairs, gram-negative cocci in pairs. All that you want to see is there. I made this painting myself for this lecture. So the objectives of this lecture is to be able to identify the most common and challenging skin infections commonly encountered in the outpatient and inpatient practice, recognize some of the complications associated with these skin infections, and to be able to treat these infections, and when surgery is needed, to be able to determine that. So when you see skin infections, you can divide them according to the site. So when impetigo is usually located in the epidermis, erysipelas in the dermis, cellulitis in the subcutaneous tissues, fasciitis of course in the fascia, and myonecrosis in the muscle. So let's start with a case. 2-year-old boy presented to your clinic in Dominican Republic. You went there for a mission. He was complaining of multiple crusted lesions in the face. In addition, he had these lesions around the eyes and in the scalp. And you remember that a week ago you had a similar case, but the lesions were slightly different. They had these yellow fluid vesicles. His father had similar lesions but were widely spread in his trunk. What do you guys think he had? Impetigo. Very good. And if we go back to the other slide, what do you think the patient that I saw 2 weeks before this had in the skin, had with these vesicles? It's also impetigo, but they are slightly different. There are two types of impetigo. There is your crusted impetigo and the bullous impetigo. The crusted form, that's the most common one, is secondary to group A streptococcal, whereas the bullous form is secondary to Staph aureus. Usually the patients present with minimal disease, but when they are malnourished, the disease can be as bad as the one that you see in here. It is highly contagious, so you may see if patients are not careful enough, you may see outbreaks in the daycare, at school, when the kids share towels or cloths or things like that. The treatment of choice is topical mupirocin. When the lesions are severe, multiple, or in severe cases like the one that we're seeing there, the treatment includes dicloxacillin, cephalexin, or clindamycin. Penicillin used to be the drug of choice. It's no longer the drug of choice because occasionally Staph aureus can be involved.
So the picture on the bottom left there is sort of a clear definition of the term cradle cap, right? I mean, it's
Yes.
It's a dense, diffuse lesions all over the scalp that are crusted and so forth.
Yes, with the honey crusted. The classical terminology is the honey crusted scab, surrounded by erythema around the lesion. See the eyes of this poor patient. You see all the yellowish crusted lesion. And then in here, the blisters have yellow fluid. So again, impetigo is classically caused by group A streptococcus. Staph aureus can be involved. You can, when the Staph aureus is the cause, you can see blisters, and ulcers with crusted lesion is more likely due to group A streptococcal, candy-like crust, varnish-like. And if you wanna be sure what's the etiology, you can get cultures under the crust. Sometimes has been associated with post-infectious glomerulonephritis, but not with rheumatoid fever. Okay, so you are in your infectious disease clinic, and this 70-year-old male presented to your clinic complaining of erythema in the face, fever, chills. What do you guys think he has? Very good. That's Erysipelas. The most common cause is group A streptococcal. However, other streps can also cause it. Most of the time you see it in the lower extremities, about 70 to 80%. It can be associated with lymphedema. In such cases, it may relapse. Some patients need chronic prophylactic antibiotics. And then, of course, the classic peau d'orange. Anybody here speaks French? Richard, you speak French?
No.
I don't. How will you? How will you pronounce that? Peau d'orange.
Yeah, probably
Peau d'orange. Peau d'orange. Yes. Which basically.
It's obvious I don't speak French.
What basically says that is the description is that the borders are erythematous and well elevated, so you can pass your fingers through that and you can see how it is. Personally, when I see an infection, I always, when I go and see patients, I wear gloves, whether they are on isolation or not. And when I have to see a skin lesion, I like to palpate. So, because I have my gloves, nothing is going to happen. But it helps me to determine how the borders of the lesions are. And we just had a beautiful case of shingles, just because, and we were able to distinguish it. It was very early on, because when you palpate, you can feel the lesions. So you look and palpate. That's always important. So again, we talk about advanced raised, sharply demarcated borders. Systemic toxicity can be seen as opposed to cellulitis. Cellulitis is more indolent. With erysipelas, the patient appears slightly more toxic. Staph aureus can cause erysipelas when there is purulent seen in any of the sites. So the next case is a 40-year-old male who presented to emergency room complaining of progressive erythema in the right lower extremity. In the left lower extremity, and you did Doppler to rule out DVT, and it's negative. So obviously this patient has cellulitis. You can see that the borders are less demarcated compared to erysipelas. He didn't have fever, and the infection, remember, is in the subcutaneous tissue, as opposed to erysipelas that is located in the dermis. So that's why the borders are more diffuse. Again, subcutaneous tissue, Staph aureus occasionally can be seen, group A strep. Remember that occasionally you can see cellulitis associated with surgical wound infections. When a patient presents with wound erythema rapidly after surgery, and the patient also has fever within 48 hours after the surgery, the main bacteria that you have to suspect is group A streptococcal. Remember also that Tinea pedis can serve as a source of entry of the streptococcal, and these patients can have recurrent group A streptococcal cellulitis. So you have to treat the tinea. Remember that patients that have chronic lymphedema can also have recurrent cellulitis or erysipelas, and also patients who have Scabies. And then at the previous wound site, you can see recurrent erythema and recurrent cellulitis, just because through that the streptococcal keeps coming back and cause a problem, and the venous system is not the same. Obviously, if the patient looks stable enough, doesn't look toxic, you can treat as an outpatient with penicillin, provided that the patient is not MRSA colonized or doesn't have any signs of pus. You can treat with augmentin, Keflex, clindamycin. Occasionally you can use levaquin, but we really like as an alternative to beta-lactamics or clindamycin. So this is a 45-year-old male who presented with a papular lesion that rapidly progressed to a pustular lesion in a day. The patient say that he had a spider bite. So you know that every time they tell you the patient had a spider bite, you have to rule out MRSA. There are some risk factors for MRSA infections, including chronic skin conditions. Also, patients who are incarcerated, patients who play contact sports are the patients who have risk factors. However, MRSA colonization can happen to anybody. It's so widely spread in the community. Again, sometimes patients share personal items and they get colonized, and then when they have skin cuts or abrasions, then the MRSA goes in there and causes infection. Patients who have skin-to-skin contact also are at risk. Crowding, makes them more prone to be colonized by MRSA. Some people get colonized with MRSA and never have an infection, and eventually the colonization goes away. Some people get colonized with MRSA and go to a surgery, and they have surgical wound infections. On them, it has been proven that decolonization prior to surgery diminishes the incidence of surgical wound infections. Some people get colonized with MRSA and develop MRSA furuncles, and they may even have bad MRSA pneumonias, especially after influenza pneumonia. Some people get exposed to MRSA and never get colonized, and it appears that there is some genetic polymorphism that plays a role in this. Again, it was the MRSA, as we know, it was first described in 2001, or at least the more cases were seen at that time. MRSA has been associated, as we know, soft tissue infections, endocarditis, pneumonia, and osteomyelitis. This article came on Clinical of Infectious Diseases in 2003. So you'll hear that some people will say, oh, so this patient has cellulitis, and it may have come from a furuncle. So Staph aureus, including MRSA or group A strep, can be involved. So Clinda appears a great drug because it will cover both. However, remember that not all the MRSA are sensitive to clindamycin. And that was, described on this paper. Remember, if you're considering to treat MRSA with clindamycin, you have to make sure that they do the D-test if you're able to culture the sample. The D-test tells you if there is any inducible resistance to clindamycin, and that they put the erythromycin disc next to the clindamycin disc, and they incubate the erythromycin disc with colonies of the MRSA, and if it start invading the disc of the clindamycin, that's a D-test positive, so you cannot use clindamycin. So use it only if you have a lab proven that tells you, yes, it's okay to use the clindamycin. The next case is a patient who presents to your clinic, 20-year-old, who likes to bite the nails and then develop painful erythema around the nail bed. What do you think he has? Paronychia. And what's the most common organism? Staphylococcal aureus is the most common organism. Streptococcus can also be involved. If the patient likes to bite the nails, anaerobes can be involved too. Also remember that the differential diagnosis of finger lesions like this include herpetic willow and also a felon. The felon is an infection of the tip of the finger, and that one is a serious one because it can spread to the bone quickly and cause osteomyelitis. So the treatment of choice is usually directed to Staph aureus and of course MRSA in these days, and of course streptococcal, and if the patient does nail biting, anaerobes. This is Richard. You like this slide?
Oh.
Yeah. Yes. So the next group of infections is the one associated with cat and dog bites. This is a paper that we published in the Lancet, including Richard Ehlor, myself, Dr. Gompf, my husband, Dr. Lamarche, and Dr. Gompf. And this is related to septic syndromes associated with cat and dog bites. So what is important to know about cat and dog bites, of course, there are some brands of animals that are more prone to, of dogs that are more prone to cause this, including the pit bull and the German Shepherd. Kids are the most common victims just because of their behavior. On kids, the most common site of infection is the face, just because of their size. Females, for some reason, are more prone to have cat bites than compared to males. And as far as the most common organisms, of course, we have the Pasteurella and the Capnocytophagia, along with anaerobes from the pet's mouth. But in addition, methicillin-resistant Staph aureus that can colonize the victim or the pet or both can be associated. So you have to treat not only your anaerobes, the Pasteurella, the Capnocytophagia, but also the MRSA. As far as sepsis syndromes associated with cats and dog bites, is commonly seen associated with Pasteurella and Capnocytophagia in patients who are immunosuppressed, including leukemic patients, patients who have had a splenectomy, or alcoholic patients, malnourished. In these patients, they can have bacteremia from these two organisms. They can have even meningitis or endocarditis. The treatment of choice is, if the wound is big, you have to have the surgeon to debride that and get cultures. The treatment of choice is with piperacillin tazobactam or ampicillin sulbactam or meropenem, plus coverage for MRSA. Yes. Yes, sure.
Little known fact, that's actually Dr. Cassanius' brother who's in the picture. He had a cat bite, a dog bite exposure, and then the silhouette there in the cage, that's actually me. I'm modeled for that.
Yes.
And why am I doing
Nice.
this? Because it's not because of the dogs around, but look where the bird is positioned right above my head. I was very startled.
Yes. Yes. Yeah, he was going to open that. One point as far as cat bites, because of the size of the cat's teeth, they have a tendency to cause osteomyelitis more as opposed to dog bites. So you always have to make sure the patient doesn't have osteomyelitis when they have cat bites. Well, we already say that. About 50% of cat bites get infected. Okay. So the next case is a patient who is a heavy alcoholic drinker, was fishing on clear water, swam in the water, and then a week later came back with cellulitis and widespread blisters that rupture, and you can see these. What do you guys think he has? And what's the syndrome called? Necrotizing fasciitis. So what this slide bring us is to the one of the complications, or the thing that we have to keep an eye open when we see a skin infection. Especially if the cellulitis doesn't look normal to you or looks pretty bad, you have to think about necrotizing fasciitis. Because of these patients went and swam on salt water and is a heavy alcohol drinker, you have to suspect Vibrio vulnificus. Other cases of bad cellulitis include, of course, group A streptococcal can spread to the fascia and cause all these, and Staph aureus. The patient occasionally may present with bad cellulitis like that, but sometimes he may present only with edema and not very impressive erythema, and the pain is out of proportion to the findings on physical exam, and the patient may look very toxic, and you're like, what's going on in here? So you have to do an MRI and have the surgeon call to make sure the patient doesn't have necrotizing fasciitis, because the infection is underneath and it may not be in the superficie. So unless they open it, they won't see anything. There are grossly two types of necrotizing fasciitis. The type 1 is usually the polymicrobial, in which you can have Bacteroides, Peptostrep, gram-negative rows, including E. coli, Enterobacter, and Klebsiella. And the type 2 is usually due to group A streptococcal. Of course, risk factors include trauma, diabetes, cirrhosis, but the most important thing in this type of necrotizing fasciitis, when you see the patient and he's so septic, you don't know if he's going to have type 1 or type 2. You may be suspicious depending on the clinical history, but you have to treat them broadly as if he had polymicrobial infection, because you have no time to waste. So you have to call your anaerobes, your gram-negatives, your MRSA, and you even have to, and then you have to call the surgeon, and you have to even give him IV immunoglobulin. They suspect that also when the patient, they may have a lot of pain or they may have anesthesia in the area. It's so bad that it progressed from macular to bulla rapidly, from severe pain to numb, from red to blue-gray, and from edema to crepitus, just because of the gas-formating organisms. It's a surgical emergency. Again, we discussed the treatment, and then, of course, another thing that I didn't mention, you have to include clindamycin on the treatment in order to decrease the toxin production. And IV immunoglobulin. Why IV immunoglobulin? Because it binds the toxin-presenting T cell, and that prevents all the activation of the cascade, because this toxin acts as a superantigen. Another thing is that a patient may present with cellulitis, and it may not be necrotizing fasciitis, but if the patient looks toxic, treat it as if the patient had toxic shock syndrome. And again, in that case, you also have to include clindamycin as a part of the treatment, with vancomycin or daptomycin, or whatever you're including. So septic patient with skin infection is necrotizing fasciitis or toxic shock syndrome. Occasionally, you can have clostridial cellulitis. That's usually seen in patients who have a surgical procedure involving the GI tract. It is usually Clostridium perfringens or septicum. Occasionally, it may involve the muscle. It could be so bad that it can travel from the abdomen down the leg. Treatment, again, basically what I discussed, clindamycin, beta-lactamase inhibitor, or carbapenem. Remember that the gas-producing organisms are not just your anaerobes, but Klebsiella and E. coli can do the same. We discussed the cases of Vibrio vulnificus. Don't forget that can happen. Saltwater exposure, especially in our area in Tampa. April to October. Patients with liver disease, alcoholics, and occupational risk. I always like to, when I see cellulitis, I always like to ask for hobbies. If they had a contact with animals, with water. Sometimes the patient tells you, sometimes they don't, and you have just to keep asking. The characteristics of the pain, etc. The treatment of Vibrio is cefotaxime, doxycycline, or quinolone. Can you have non-traumatic spontaneous gas gangrene? Yes. The example is neuropenic colitis or typhlitis. Sometimes patient can have a perforated diverticulum, and that can happen, or volvulus. The mortality is 67 to 100%. Again, we all know about the symptoms of neutropenic colitis. I call it like the appendicitis of the neutropenic patient, because it's when you press it, the patient just jumps on that area. So in the CT, you'll see the ileocolon is affected. Why? Because the cecum is the area that is very distended with less vascularity compared to the rest of the colon. So the stool stays there for longer, so all the bacteria multiply. And then the treatment right there, flagell, saucy, meropenem. Clostridium septicum is the most common, but gram-negatives occurs are part of, when you usually see an anaerobic infection, it's usually polymicrobial. An anaerobe alone doesn't come just by itself. Gram-negatives are also part of the picture. What you see here is a case of a patient that we had at Moffitt several years ago with necrotizing, with typhlitis or neutropenic colitis. He ended up going to surgery, but you see all the bullas that travel from the right lower quadrant to his leg. And even you see gas even traveling to his leg, right below his bone. Of course, the patient didn't make it, and you can see the cecum all necrotic there. So it can be that bad. So we get very serious about patients who are neutropenic, high-risk neutropenic, that complain of right lower quadrant pain. We don't want it to progress like that. Don't forget, now we're talking about necrotizing fasciitis and all that. Don't forget your Fournier gangrene, usually seen in diabetics. However, patients who go for any type of genital procedure like penile prosthesis or anything like that, they can have a Fournier gangrene. It can also happen in females in the vulvar area. If you don't treat accordingly, these patients don't do well. They sometimes need hemipelvectomy and very aggressive procedures. So, okay. The next case is 20-year-old male patient who went to your clinic to see you female, went to see you and presented with several erythematous papular lesions in the abdomen. She said that she went to a pool party with her friends, and they were in a hot tub. So what do you guys think she has? Folliculitis secondary to what? Pseudomonas, yes. Pseudomonas aeruginosa folliculitis, or it is also called hot tub folliculitis. It usually appears 1 to 3 days after exposure. The longer you stay in the water, the more risk you have to develop it, and that's because the water may not have enough chlorination. It resolves spontaneously. You don't have to do anything about it. It is not contagious person to person, but only to people who swim in that water. Remember that folliculitis can also be secondary to Staph aureus, Candida, Malassezia forfora, and in HIV can happen. Eosinophilic pustular folliculitis can be present on these HIV patients. The treatment of choice is steroids. Most of these folliculitis resolve spontaneously, but in severe cases, then you have to treat the organism that you're suspecting. This is the next case. 50-year-old male who likes to play soccer, comes to see you in the clinic complaining of these wounds between the toes and under the axilla. What do you guys think he has? Tinea, right? Tinea. So he had Tinea pedis, intertrigo under the axilla, and Tinea barbarie. This is the one in here is a bad case of Tinea pedis that's already crusted. You see here on the left lower corner Tinea corporis, and then you see Tinea cruris. What are the most common top 3 dermatophytos that cause tinea? Trichophytus rubus, canis, and this one that I cannot even pronounce. Flocculosum, yes. The differential diagnosis of Tinea cruris is erythrasma. Erythrasma is caused by Corynebacterium minutissimum. What you'll see in physical examination is it looks just like Tinea cruris, but you'll need a wood lamp to see the coral pink fluorescent. The treatment of choice is erythromycin for 7 days or topical clindamycin. However, if you have yeast intertrigo of the groin, Tinea cruris, or erythrasma, one thing I found very interesting is that topical azoles work for all of them. So you don't even have to kill yourself trying to get a wound, a wood lamp to see if it fluoresces or not. You can just give topical azoles and work for all of them. Yeah, which I found very interesting. I said, why? If it's a bacteria, why is it?
I saw a patient with that, and I really want to get a wood lamp to look at it, and I found a place that had wood lamps and could look at it.
And was it fluorescent?
It did emergency room, it didn't fluoresce.
Oh.
It just had tinea.
I saw one in the dermatology clinic here. I think it was fluorescence.
Very good. It was in the axilla. Very good.
Usually the dermatology clinics have a woods lamp, but that's, I don't know if they have them in ERs, but you can usually, if you go to a dermatology clinic, I know at the VA you can get a woods lamp.
Now, but keep in mind that if the patient just spat and didn't rinse well the soap, that can cause falsely, it can fluoresce in the lamp falsely without having that. So you have to ask the patient.
Because a lot of soaps have fluorescence to,
Yeah,
like especially like laundry soap to make your clothes look brighter.
yeah.
Cold water and then make sure you clean it well.
The next case is a patient who lives in Lakeland, presented with nodular cellulitis after working in the yard. What are the possible etiologies? He presented with a nodular lesion in his right upper extremity, like that. Like what? Yeah, but what's the cause? Sporotrichosis, nocardia, and Mycobacterium, tularemia too. Yeah, less likely in Lakeland, but yes. So this is your differential in nodular lymphangitis or nodular cellulitis, sporotrichosis, nocardia, Mycobacterium, marinum, chelonium, fortuitium. Those are your rapid growing Mycobacterium, tularemia, and even leishmania, but here we don't see that. What I'm trying to tell you is that not every cellulitis is due to strep or staph. Yes, those are the most common causes, but remember to ask about the hobbies. Remember to look at the appearance. And we just had a case that had, yes, he had cellulitis in the ankle, but he was describing sharp pain, electrical, and if you look at his foot, traveling on his first toe, there were few papular lesions. You couldn't even touch it, and the patient had prolonged neutropenia. And he was also complaining of the second toe was painful too. So he had early shingles too. So remember that you have to ask, take your time, ask all the questions, and think in your differential. So how do you get Mycobacterium marinum or fish tank? Before the 62, the pools didn't have enough chlorinated water was not the best. So after that is basically the pools are better in that sense. So you can get fish tank after cleaning the aquariums. But of course, crab bites, some spines of these creatures can cause the same problem. They appear as a single ulceral lesion and lymphatic spread. Treatment: clarithromycin, doxycycline, or Septra, doxycycline plus Septra, usually for 3 to 12 months. You can get Mycobacterium marinum after going on a pedicure. It's more associated when there was an outbreak. The outbreaks that have been described is more in females, and the first one was described in California. After the females just shaved their legs and went in there, and some of them had minor cuts. So I love to go to the pedicure. I do, but I try not to shave right before. And if I have a wound, I wait until it's healed. So Mycobacterium fortuitum is a rapid-growing mycobacterium. Of course, we discussed, and you'll see a papular lesions that travel in lymphangitic fashion. The treatment against Cipro, Claritro, or Doxy. If for minor cases, they can clear spontaneously. So these are rapid mycobacterium outbreak. Nail salon foot bath in California for M. fortuitum, 61 patients. This is the disease duration. They were treated for 4 months. They were sensitive to most antibiotics. Okay, these are other rapid mycobacterium outbreaks associated with foot bath. Facelifts. So some of every time you see a patient with surgical wound infection after plastic surgery, and it's growing an AFB, of course, you have to think in rapid-growing mycobacterium, especially Mycobacterium fortuitum, occasionally abscessus. So this was a contaminated methylene blue. Lipoturis from Dominican Republic. They also have some nodules, and it was also a rapid-growing mycobacterium. Okay, this is a case from Moffitt. Neutropenic patient presented with, yes, don't say it. Neutropenic patient for 4 months due to refractory leukemia on a prolonged and complex IV antibiotics, presented with neutropenic fever and multiple lesions like the ones that you see there. What is something that you have to suspect in somebody that is immunosuppressed or with fevers and septic picture with skin lesions? Candidemia is one, yes. What else? Candidemia should be in your differential diagnosis, yes. Yeah, which is disseminated, candidemia, or even disseminated trichosporum can cause skin lesions, but this patient didn't have that. And she was like on triple antifungal therapy, so she didn't have that. Ecthyma gangrenosum. So she ended up having Ecthyma gangrenosum, which is a skin infection that starts with a erythematous papular lesion that rapidly spread and becomes necrotic. It's more commonly described associated with Pseudomonas, but any other gram-negative can do the same thing. And on her case, she had a CRE, carbapenemase-resistant enterobacter. Yeah. And so the blood cultures were positive for that, and the skin lesions were positive. Well, actually, it was I think we gave her. We gave her that, and then we tested her for chloramphenicol, and it was sensitive. But when we were about to use it, the family and everybody decided to put her hospice because she had no hope for her leukemia.
She came back with this one.
Yes.
CRE.
Yes. So moving to the next case of skin infections. This is a 10-year-old boy who presented with multiple ulcer lesions in the gums. So he had what? Primary HSV or herpes gingival stomatitis. Of course, your differential diagnosis include Aphthous ulcer from idiopathic etiology, or of course secondary to Coxsackie A. But he had what? Oh, and Behçet's. Yes, good point. Or even lupus, too. But he had herpetic gingivostomatitis. Later in life, when he grows, he can reactivate a lesion in the lips or in the nose. The case at the bottom is a genital HSV, and the other case is herpetic willow. Those are your presentations for herpes 1 and 2. Remember herpes gladiatorium that occur in patients who play sports, contact sports, and they can have herpetic lesions in the chest, neck, and face just because of the contact sport. Remember your atypical presentations of HSV, which is a linear erosive herpes, or the Necrotizing that's classically seen between the buttocks that is recurrent. What is the treatment of resistant herpes simplex or zoster? These type of herpes are commonly seen in HIV patients or transplant patients who are exposed a lot to acyclovir. So they can get resistant. Foscarnet, idofovir, and even imiquimod, topical tefluridine in genital, particularly for genital herpes, and even interferon alpha and tefluridine has been tried before. This is your classical case of shingles with the blisters, dermatoma distribution, no question. The problem is when you see patients like that, neutropenic patients or immunosuppressed. They may not have neutrophils to produce like the blisters, or for different reasons they don't have the blisters. They just have hemorrhagic lesions. The key is the dermatomal distribution and the borders that are serpendigenous. Remember your Hutchinson sign. That's the lesion in the tip of the nose, and it can also involve the eye. So if you see a lesion in the tip of the nose and you're suspecting shingles, you have to call your ophthalmologist to make sure that the eye is not involved. That's because of the nerve distribution, nasal branch of the nerve. What is Ramsay-Hunt syndrome? What is that? Lesions in the ear from BCV. The patient can have ipsilateral paralysis, taste changes in the tongue, and that's because of the distribution of the facial nerve. So if you see lesions in the ear, could be shingles affecting the facial nerve. A baby presented with papular lesions with central umbilication, mollusco contagioso. In kids, may be associated with daycare, sharing personal items. In teenagers or adults, is considered a sexual transmitted disease. The treatment is curettage or laser resection of the lesions. The next case is HPV. HPV can happen in the mouth, in the rectum, in the genitals, or even in the hands. Remember that HPV is associated with malignancy, head and neck cancer, rectal cancer. But the next case is a patient who went to sleep in a cheap hotel and presented with multiple lesions in the linear fashion. They're not painful or anything like that. So that's bed bugs. The diagnosis you can suspect because when the patient tells you, I was fine, I went to sleep in a hotel or to another place than not my home or whatever, woke up with these lesions. They were not there. And the best diagnosis is to see the bugs under the matrix. The treatment is very difficult. I think you gave a presentation about that, no? You had to sometimes bring special companies to clean the house, and I mean it's very, very hard to get rid of these bed bugs.
Yeah, I was at Walgreens the other day, and I noticed I was looking at different stuff, and they have now bed bug spray. So you can buy a can of bed bug spray and take it with you to a hotel and spray your
matrix. Good.
mattress and whatnot. So
Good.
I don't know if it works or not. This is not a commercial endorsement.
The next case is a patient who presented to your clinic complaining of multiple papular lesions between the fingers around the belly button and the nipples, and under the axillary region. He said that his uncle who lives with him is 90 years old with leukemia and has lesions like this. So what is that? Scabies. What's the name of a crusted Norwegian scabies seen in HIV or immunosuppressed patients?
Of course, they now call it crusted scabies because the people in Norway complained.
Okay, so
Right? Why did we call it Norwegian scabies? It's not coming from Norway.
It may have been recognized or published by somebody in Norway,
yes.
but I'm sure the people of Norway did not know.
The treatment of shoals is topical permethrin and oral ivermectin. Remember your non-infectious wounds for which they may consult with refractory wound infection. This is a case who presented complaining of erythematous papular lesion that progressed, ulcerated, has required multiple debridements, and each time gets worse. Pyoderma gangrenosum. How do you make the diagnosis? Clinically, and in the biopsy, what do you see in the biopsy? A bunch of neutrophils. That's what you see. That's all. So it's clinical, and that's what the biopsy tells you. And one thing is called pathergy. What means is that every time the patient has a procedure or they do something, it gets worse. That's pathergy. Usually the borders are purpuric like that, and there is this yellowish exudate. It's usually associated with inflammatory bowel disease or other autoimmune problems, and even with malignancy. So these are different examples. These on your left, different examples of pyoderma gangrenosum. What you have on your right is erythema nodosum. That they can call you to tell you that the patient has cellulitis or furuncles, and that's actually erythema nodosum. The most common associations to erythema nodoso include streptococcal infections, TB, Yersinia, Mycoplasma, Lymphogranuloma venereum, Salmonella, Campylobacter. Fungal include Coccidio, Histo, and Blasto. Medications include oral contraceptives, sulfa, gold, and iodines. And please, every time you see a skin infection, do not forget the great imitator syphilis and also your HIV, which is illustrated right there. So when you have a skin infection or skin problem, you don't know what's going on, test the patient for syphilis and HIV.